My name is Karen Gallo. I'm a physical therapist here at the hospital. I'm the director in physical medicine. We're up on the 3rd floor, and we travel kind of all over the place in the hospital, but I also represent physical, occupational, and speech therapy. So I'm going to talk to you a little bit about those services. Brought some toys to liven some things up, hopefully. And as I believe it was Kevin that was here just now was saying about muscle wasting, and people don't think about the ability to sit to stand, and that's kind of my job. So I'll talk to you a little bit about that. So I'm going to have a presentation up here, just going to talk with you about the services and just give you some examples along the way. Anybody ever had physical therapy? I mean, one in the room definitely has. Look at all of that. Holy moly. Anybody had occupational therapy? Oh, there we go, a little bit on that one. Anybody ever had to have speech therapy? Now that's going to be the more rare one. Okay, we got a little bit there. So you know a lot about physical therapy, probably. Mostly orthopedic conditions, probably mostly people understand it for that from the outpatient perspective. But physical therapists can be involved in a lot of different aspects. We want to try to be involved in the people's quality of life and their potential for good movement and hopefully pain-free or less pain in their lifestyles. We can work with directly with the patients. We also work with families and caregivers, and really all ages from newborns straight up to the oldest of the old. So there's therapists that work in all of those different settings. Here at the hospital, we work in physical therapy with our inpatients, so patients that have just had surgeries. That might be orthopedic. It could be someone who has had abdominal surgery. It could be someone with pneumonia. It could be someone with a stroke. So we work in all different areas to try to get people mobilized early. Gone are the days of laying 2 weeks in the hospital, right? 2 weeks in the hospital plain out is gone in most cases. But we get people up the first day after surgeries with their orthopedic surgeries and get them mobilized quite early. Certainly nursing is involved in that as well, but if we need to teach the people how to move with their new situation, move a little bit easier, that's what we're doing. As far as outpatients, we also treat people that come into the outpatient setting. That may be people we saw in the hospital and then they come for physical therapy afterward. We're seeing them to work on their mobility, to get them stronger. Sometimes it's a balance issue. Many of you may have heard of vestibular or inner ear problems with balance. We can also work with patients with that, which is a smaller part of the physical therapy profession. I work with patients that have lymphedema. I don't know if anybody else has ever heard of lymphedema. It's a chronic swelling. Most often people know about it for patients that are post-mastectomy. They can get very bad swelling in their arm. So I work with patients that are have had that swelling, or also in their legs. There's special manual techniques. We can work with that as well. We also work with manual therapy. We work with getting that joint or part of the body moving. We work with stroke patients who have lost motion due to the stroke. So a lot of different areas. Physical therapists, in both in an inpatient and outpatient setting, we have here at the hospital just physical therapists, but you might run into places that have physical therapist assistants. So the differences in the two is PTs have a bachelor's, master's, or doctorate degree, depending on when they graduated, and physical therapist assistants have associate degrees, but both have licenses and both are have to take the state examination to be licensed. And I think it's now by 2015 that the American Physical Therapy Association all of the programs will have to have doctorate level programs. So it depends on the physical therapist that you meet. I started out with my master's degree, but then got my doctorate a little bit later. I've been a physical therapist for 15 years. So it's changed quickly over the years on levels of education. A couple other things. So we work with different mobility devices. So we're going to be the ones maybe that teach you how to use crutches, walkers, canes, even if it's only for a temporary. I brought some toys to kind of show you a little bit about what we do in physical therapy also. This is a kind of a newer device people are using for ankle or foot injuries. This is called a knee walker. Didn't know about this when I first graduated, and it's still certainly not that long ago. This is what you would use if your ankle or your foot was broken. You can put your knee on top of this and kind of scoot around, and it makes life much easier instead of having to hop with a walker. If anybody has ever broken something that they weren't allowed to put their weight on their leg, it's really hard to hop on crutches or hop on a walker. Anybody ever had to do that? Oh, it's terrible, right, to have to do that. This would be my choice if I ever had to do it. I'll knock on something that I don't have to. So a lot of people familiar with physical therapy, right? Any questions about physical therapy I can answer right off the bat? All right, I'll talk about some of the other therapies that we have also. Occupational, yes, go ahead, please.
I was just going to ask,
Yeah.
Is that device rentable? Or
Yeah, it is.
Oh, okay.
Actually, a lot of insurance companies have been covering it, which we're thrilled about for our patients. But yeah, this is a rentable item. I can't remember, it's not that much a month that I remember. Some of the insurance companies are paying for the rental, or sometimes we'll get the patient a walker because they can use that in certain certain situations, and then they'll pay for that. And then sometimes the family will just want to go ahead and rent this device also. We have a nice little walker bag on here that some of our volunteers have made, so we're just kind of showing that as an example, but it fits on this as well to carry your cell phone, to carry your tissues, whatever else you need in here around when you're walking. But yes, good question. Yeah. Occupational therapy. We only kind of had a couple that have had to have occupational therapy. People say every day to our occupational therapist, why do I need an occupational therapist? I'm retired, I don't need a job, all of those things we get for that. So our poor occupational therapists, they have to explain that really your occupation is what you do in your everyday life. It's your job for the skills of living. So that's how we try to explain it to people, and so that they can understand that it's about your everyday activities. So occupational therapists are often involved in dressing, bathing, getting up out of bed, going to work, or enjoying leisure activities, kind of adapting the environment or working with you so that you can do those things that you want to do and need to do every day. So those, our occupational therapists are mostly involved in that part of occupational therapy. Here in the hospital, you know, getting someone who's had an illness or injury, that just getting bathed and dressed in the morning. I mean, you know, when you're not feeling so well, that it can be a task in itself to be able to do that. So we can help to teach different techniques to conserve your energy, to show you different types of equipment that can help you get dressed if you're not allowed to bend over, or those types of things. So we can work on that. Both physical and occupational therapists work on what we call functional mobility, so the ability to get out of a chair and out of bed and to get around. So that's where we kind of cross over. So a lot of times that's why people think we're kind of the same thing, but it is a separate degree. Most of those therapists have bachelor's or master's degrees, with them also moving toward doctoral degrees, and they also have an occupational therapist assistant that is a degree as well, that's similar to a physical therapist assistant in as far as the degrees are concerned. Here at the hospital also we have outpatient occupational therapy, which mostly is patients with stroke and also with hand problems. Physical and occupational therapists can kind of be specialized in hand therapy. A lot of times it's occupational therapists, so they'll work on different hand surgeries, injuries. Occupational therapists can also be working on patients' thinking skills and cognition, and how that fits into everyday life, how that fits into someone's work tasks, say after they had a stroke, or how it just fits into their everyday tasks, the ability to pay your own bills and those types of things. Here at the hospital also, in occupational therapy, from newborn really to the oldest, here in the hospital we have a neonatal intensive care unit, and we have an occupational therapist who work with our preterm babies on just the earliest development, so they can have hands-on work with the babies and their families to work on that development. So that's another part that's kind of a more little known therapy intervention. I'll show you some of those things I was talking about. See where I have my other tools here. All right, this is the obvious one. Everybody got that one? Shoehorn, right? So nice and long-handled shoehorn. So if you can't reach down to get your shoes in, or if you're not wearing slip-ons easy like me, you can be able to reach down. People who have hip replacements aren't allowed to reach down and over for any period of time, so we need to show them how to use the long-handled shoehorn to be able to do that. This one, not a device to pick on people. That's what it kind of looks like, right? Oh, there goes the bag. This is what we call a dressing stick, and it's pretty amazing. If it gets out of the plastic, that is. Sorry about that. Grab that on my way down. So, dressing stick. Think, well, what is that going to do for me, right? So, if I were to have shoes on that were had backs, this little part here can sneak right into the back and flick your shoe off. It also can bring it over closer to you. You can also use this so if you have your pants, you put them on the floor, you put your foot in the pants, you can use the hook to help pull it up so that you don't have to bend over and pull it up. So we can teach people how to use that, and that's normally in occupational therapy. Probably the device that us and most of our patients get the biggest kick out of, and they just think it's the greatest thing. If you ever haven't been allowed to bend over, it's difficult to put your socks on if you can't bend over, isn't it? You can't put your foot up like this maybe, or you're not allowed to do that. It's called a sock aid. So this is pretty cool. This is what occupational therapists also can show you. And I'll just demonstrate. So you have this thing and you have your sock. And you put your sock over this thing with the bottom on the bottom, top on the top. Just pull it all the way up. I'll probably have it on backwards. No, I have it right. And then it's got these nice long handles. So normally you'd be in a sitting position, but I'll try to be talented and do it in a standing position. You drop it down without being able to bend over, or either it's painful or you're not allowed to. You put your foot right in here, and without your pants getting in the way, it slides right out and your sock is on. So it's really easy to do that way. And so that's like the neatest thing we show people. They're just amazed by it, and I'm amazed by it every time it works. So what you can do is, nobody else is probably in their socks while you're here today, right? So same thing, the dressing stick can help push the sock off. Then we also have reachers. You've probably all seen those before, the little grabbers, right? So that would go get my sock instead of me having to lean over and get it. So that's a little bit about kind of things that we teach patients with occupational therapy. Work tasks are a big thing, even though, as the name implies. So a lot of times we're even working on people with the computer. Some occupational therapists work in areas that they work with patients to get them back driving. So there's lots of different ways that those therapists can be used. So I'll talk a little bit about speech therapy. Any questions about occupational therapy in general? I know you have handouts as well. Now, speech therapy or speech language pathology. Again, very varied profession, can work with all types of different patients. Speech language pathology, the obvious is speech and language, of course. That could be because of any kind of mechanical problem with the voice or even with the tongue, but it also can be because of swallowing dysfunctions. Because a lot of times patients will be referred to speech therapy for swallowing dysfunction, and they say, well, why am I going to speech? I don't have any trouble speaking, I have trouble swallowing. But that's also part of their training and part of what they do. Cognitive aspects of communication as well. So patients who have had some type of neurological problem or deficit may also need to work on their thinking skills or how to adapt because some of those thinking skills aren't as strong as they used to be. In the swallowing part of the function, when patients are seen here in the hospital, the therapist uses a stethoscope on the side of the throat to be able to listen to how things are going down, because everything in there has to coordinate. When you're eating lunch today, everything has to coordinate from the tongue through the throat. Everything has to go correctly so that it goes to where it needs to go. Risks of dysphagia are aspiration pneumonia. So some patients can get pneumonia because they aspirate. So we have speech therapists that see our patients in the hospital oftentimes to check to see if it was aspiration pneumonia versus some other type of pneumonia, so that we're not inducing a pneumonia. Also, if the bedside evaluation doesn't quite give us enough information, our speech therapists also are working in the radiology area where they have a special compound that they mix with the foods, and there is an active x-ray. So it's a video of you swallowing. It's really great. It has, you can see the mouth and you can see the tongue, the teeth and everything, and exactly where the food is going and exactly how it's coming down. And then speech therapists can work with patients with different diets or with different strategies to be able to swallow safely, which of course is so important in our everyday life. Speech language pathologists, again, work both in the inpatient and the outpatient area. Kind of more rare here, but occasionally we might have patients with a tracheotomy. So that's the breathing valve in the throat. And they can work with patients that may have had that. There's a special valve that's mentioned on your handout called a Passimure valve that helps patients speak, because once they have that hole there, they have difficulty getting any kind of volume or speech through. So they can also work with patients that have that. Speech pathology, see if I missed anything else. I think that's about all on speech pathology. Is there anything else I can answer about speech? Yes?
Do you work with patients who have had a stroke and as far as affects their speech?
Absolutely, yep. Speech language pathologist would work on that. Like I said, sometimes it's the muscle component of speaking because they have weakness in the facial area or even the tongue. Sometimes it's the finding of words that is trouble, so it's kind of that brain connection between from the brain to get the words out. So sometimes it's putting those words together in the appropriate manner. So yeah, sometimes it's part of the thinking skills and sometimes it's part of the muscle part, but speech language pathologists would work with those people as well. On an outpatient basis too, so even if they're done with their acute or rehab type stay, they would continue with those services afterwards. Yep. Yes?
My wife and I have had the privilege, both of us, working with both physical therapists in Lids, and they're both very good. We know both of them very well, and I'm pleased to report that you can be well served in an outpatient basis by having those people so close and so very good.
Mm-hmm. Yeah, I think we have a lot of choices here. We're certainly partial, but yeah, there's a lot of good therapists that can meet your needs, and because there are a lot of different specialties, sometimes it's good to ask the questions of what exactly your goals are, and certainly all of the therapists, we work with the patient on what their goal is to work with therapy. What do they want to get out of it, so that we can all be working toward the same goal. Anything else I can answer for you? I have one more handout for you if I can figure out which book one I left it in. What I'm going to hand out is what I call desk stretches. Oh, thank you. This is a little program that you can put by your desk, and if you're sitting for any period of time, we all get tight, right? You're all going to be a little bit tight a little bit later after sitting all day today, right? Even though you're getting great information. This is a really short, like 2.5–3 minute program that will stretch most of the muscles around your body. It kind of shows you something for the hands, for the shoulders. It kind of just gets the stiffness out. We all kind of do that little stretch, right? That when we're getting stiff. We're all at the computers. Everything is in front of us, so it's important to get up and move. So part of my job here is also teaching body mechanics to the nurses and to the other staff that are here so that you can prevent coming to me for physical therapy. So this is just like a little stretch program that you can have nearby. Do you have enough? I can make some more if not.
We have enough.
Okay, wasn't quite sure of the number. Yes, how can I answer?
How soon do you start when you have a patient in a hemiplegia, with a stroke?
Yes.
Obviously it's important. Do you adopt actually that you come from the side that the patient is not able to, just to drain the side? And how soon do you start with that?
How do we start therapy with somebody with hemiparesis with weakness on one side?
The acute situation, is it immediate?
Yeah, pretty much. As long as they're medically stable, as long as there's no possibility of our activity causing any more problems, if they're having any heart rate or blood pressure problems. But most times when the patient comes in today with those symptoms, we are in their room tomorrow, starting something with them, assessing where they're at, and we'll do a full evaluation. Here in the hospital, we are ordered by the physician, but we also go to bed meetings. So then we find out about, oh, that patient has had that injury. And then someone will say, did they order physical or occupational therapy? And then sometimes we'll get involved that way by recommendations to the physician. But yeah, we're in there right away. And